going to present to you ACL injuries. My name is Michelle Montemayor.
And my name is Maldonado.
So our patient is Jeff. He's a 45-year-old father who is a businessman. He has 2 children. He's moderately active on his free time, and he claims that he was playing basketball with his children when he was running, and he suddenly cut to change directions and felt a pop in his knee. He suffered a torn ACL based on MRIs, and he underwent ACL reconstruction. He ambulates with crutches, and he does have a brace on his knee to keep him in extension. He is here to begin his therapy program. He complains of pain 7 out of 10, and he also has limited range of motion. His goal is to return to moderate activity so he can spend time with his kids.
This is our muscle grade chart. Generally what you can see here is the weakest muscles are the knee flexors. Capsular patterns usually show that knee flexion is more limited than knee extension.
This is a range of motion chart, so we targeted hip flexion extension, knee flexion extension, and ankle plantar flexion. And as you can see, the knee flexion is very limited. The normal is 135 to 145, and he was only able to perform 30 degrees of knee flexion compared bilaterally.
General anatomy of the ACL, it provides general knee stability and protection. It prevents the tibia from anterior displacing from the femur. It is the largest synovial membrane in the body. Injury causes instability to the knee, and it is the most frequently injured joint in the body as well.
It is also important to know the healing process of a ligament. So the inflammation phase does begin a couple of hours after the injury, and it goes all the way to 72 hours. This is where you see the most red blood cells, white blood cells, lymphocytes in the area, and this is where the extracellular matrix is produced. And then you go into the proliferation phase, so this begins at 3 days and it goes all the way to 6 weeks. This is where the extracellular matrix is synthesized by fibroblasts. There are a lot of fibrocytes and macrophages. There's vascular buds, and there's also elastin present. After this, you go into the remodeling phase, which is the longest phase of all of them. It goes anywhere from 14 days to 2 years. This is where macrophages and fibroblasts diminish. Their revascularization is complete. Type 1 collagen replaces type 3 collagen, and you have near normal tensile straight, and then at 2 years the healing should be complete.
Common concerns with ACL injuries. So the MOI that's usually common with ACL injuries is the knee will be slightly flexed when it experiences a valgus force, and the foot is planted when it's going through the deceleration phase. Mostly it's a non-contact injury that's usually caused from cutting maneuvers or sudden changes in direction. It's usually more common in females because they've been known to have slightly more flexed knees on landing and planting. Also, edema will be pretty severe. They'll have a lot of swelling that will push on nerves and cause pain. The pain will then cause an antalgic gait when they walk, which then will cause certain muscle balances with time, which will then further increase their instability. And with capsular patterns with knee injuries, knee flexion is usually more limited than extension, and they usually have an immediate loss of knee range of motion and function.
So the difference between non-operative versus operative, studies show that there is no long-term in terms of osteoarthritis and functional abilities between the two. Patients who undergo reconstruction are less likely to develop meniscal tears, injuries, or instabilities. An active person is more likely to benefit from reconstruction, and if other structures are injured, then it is beneficial for them not to do operative, and the rehab process will become more complicated because you now have to address all the injuries that were not, all of the injured segments as well.
Rehabilitation considerations for the rehab clinician. He or she must be aware of these following things. Whether or not the procedure was operative or non-operative, what phase of the healing process the patient's in, the type of graft that was used. Most common one is patellar tendon grafts. You can also use hamstring grafts. The type of surgery performed, whether it was an open surgery, an arthroscopic surgery, what the surgeon's rehab preferences are, other present injuries associated with the ACL, and the patient's individual goals.
So we begin with phase 1, which is the inactive phase. This is where the patient is normally immobilized. You want to target muscle spasm, pain, or edema that may limit range of motion. You can use modalities to help reduce all of these symptoms, and also you can use early range of motion until the end of this phase, and the goal is to have no more pain, no more swelling, and prevent deconditioning of the uninjured segments. So how to do this, you can perform the Rice's method, weight bearing as tolerated. The patient will perform ankle pumps with the injured segment elevated, supine straight leg raise, and prone hangs to increase knee extension. And you can also prevent deconditioning of the uninjured segment. So can you perform a straight leg raise? So if you lie supine on the ground, which is on your back, and then you will raise the injured knee all the way up, keep it extended, and then back down. And you'll repeat this to increase your flexibility.
Phase 2 of the rehab program is the active phase. This usually coincides with the early proliferation phase. The structures involved may tolerate some stress, but not too much to prevent re-injury. Main goals of this phase is to improve mobility through range of motion and tissue flexibility. Early strength and proprioception can be begun in this phase, but towards the end. So these include passive, active, and assistive exercises, and isometrics for strength. Some examples of exercises in this phase include some seated knee flexion for range of motion, supine wall slides, manual resisted range of motion of knee flexion and extension, stationary bikes with no resistance, make sure you're kicking the knees up, half squats, 45 degrees, preferably in the shallow end of a pool to reduce stresses, and short arc quad sets. So my partner's going to perform a short arc quad set. She's going to be supine with a bolster underneath her knee joint, and she's going to contract her quad maximally, so the heel is going to lift off the ground, and it's going to be like her knee joint is going to be reaching for the ground.
Okay, so now we enter into phase 3, which is the resistive phase. This is where you want to begin the restoring strength, endurance, agility, proprioception. You want to move into multiplanar rather than single plane. You always want to begin with high reps and low resistance, and you want to progress proprioception as well. So start on stable surfaces and then progress to unstable ones. Range of motion is nearly normal, and this also coincides with the late proliferation phase. So you can do this by having the patient perform full squats, deadlifts, stork stands, good mornings, cariokas, cutting drills, and you also want to introduce the treadmill. So you can also perform the stork stand. So you want the patient to stand on one leg while keeping the other one elevated, and you want to have the patient not lose their balance. You can progress this by having them close their eyes and then opening their eyes. And then you can progress to an unstable surface.
Phase 4 is the aggressive phase. This coincides with the remodeling phase. Exercises here usually mimic stresses the patient will face during ADLs. Restore functional and performance-specific exercises. Begin with less stress and then progress. Examples here include box jumps, progressive depth jumps with sprints, bear jumps, sprint drills with dribbling, and shooting drills around the world. Demonstrated simple, just shooting from marked spots on the 3-point line. Patient's going to sprint to each spot on the 3-point line, take shots, and this will improve accuracy and coordination, as well as speed and agility, and that's sport-specific activities.
And this concludes our rehabilitation program for ACL injury.